I want to emphasize 3 points. First, the prevention and the treatment of the infection disease is still the big challenge to the modern society. Within the tuberculosis, the MDR-TB and XDR-TB has emerged as an expanding threat to the TB control. The impact of the infectious disease on human society has once again triggered people's concern. And the second point, the prevention and the treatment of the infectious disease requires the support of the comprehensive social services system. It's still the important basic social function. The prevention and treatment of the infectious disease absolutely require a sound system of the social health services and concerted support. Government should promote and consolidate the infectious disease management and consider it as a basic social function. The third, the gap between the science and the technology, industrial development, and the health services demand needs to be bridged. How can policy and industrial work together to facilitate the uptake the scale-up in the countries that need them most? The prevention and treatment of the infectious disease call for faster and more convenient diagnostic reagents.
One of the activities that we had back a little earlier in June was an advisory committee to talk about TB drug development for multi-drug resistant tuberculosis. And at that meeting, one of the topics that was discussed with the committee was the use of accelerated approval regulations for developing drugs for MDR-TB and the use of earlier markers. And there was support from the advisory committee for using accelerated approval for MDR-TB. It is a serious disease. New therapies can provide a meaningful therapeutic benefit. And being able to also to look at sputum conversion as an earlier time point to be able to look at something that we can assess earlier on that would be useful in assessing the drug's efficacy and would be predictive of the ultimate effect that we would expect to see in confirmatory trials. Effects on relapse, preventing clinical failure, and preventing mortality.
A systems engineering approach might be appropriate to thinking about how we solve, in particular, the delivery problem, perhaps also the discovery side of the problem, because as we've heard, there are choke points, or when you have one part of the system much stronger than other parts, call it the drugs available but not the human resources capacity, or not the right policies, or if any part of it's out of whack, you end up with a very suboptimal approach. And so you have to have a framework, I might call it a systems engineering framework, to be able to approach systematically solving the problem at the county, country, or nation level. If you think about discovery in the life sciences business, software is accelerating the rate of discovery. When you think about the regulatory process, you need better tools. Some of it's still on paper, which is hard to believe in today's world, but better tools to shorten the cycle time in the regulatory process. Software can accelerate and enable the collaboration in certain cases while holding some things private and other things public.
We in delivery are hostage to that discovery, development, delivery chain, and we're dealt a hand of cards that we're forced to play. One of the things that makes TB potentially a little bit different from some of the other global health diseases is that while there are a lot of differences between the rich world and the developing world, there's also some remarkable similarities in the challenges that are being faced. And I just wanted to put a couple of those out. Number one is financing. Financing is a problem globally. In the US right now, tuberculosis is markedly underfinanced, and the issues are that policymakers are not engaged. There are not those sexy stories out there, and as a consequence, we don't have the resources to get the job done as well as we would like. I think, though, another really important similarity, in contrast to other global health diseases where there are expensive diagnostics and expensive therapies that work in the rich world, but we just can't apply them in the developing world, TB's not like that. I work on a day-to-day basis with exactly the same lousy diagnostics and drugs as the rest of the world does. and as a consequence are struggling with exactly the same issues as the rest of the world. The third, to me, remarkable similarity is we've been talking today a lot about the toolbox and what's in the toolbox, but there has also been mention of, but you need the carpenters. You need the human resources to deliver those goods. And the human resource to deliver TB control effectively in this country and in Seattle is at a crisis phase as well. Not only just because of lack of financing, but because of the specific skills that you need to do this.
Basically, the recipe that I would propose is, in my mind, quite clear. You have to have a government that has leadership and that has the stewardship capacity to actually do what needs to be done in terms of partnership with other agencies. Second part is the partnership with other agencies that are operating in countries, the non-state providers, the NGOs, the faith-based organizations. They are all out there delivering care. They must be in a mechanism that is well coordinated and through which then the care is of the highest standard. And the third part, which is essential, is actually the civil society. And this has been raised very clearly. Civil society activism are essential. We have other international bodies that are there to provide norms, and we provide norms through consultation with the best experts normally, and we try to put them down and to help the countries to put them down into practice. But without one of these components, we are always going to have problems, and in order to solve this, the coalition is what is really necessary to fight a disease like this one. Doing it, sector by sector alone or in isolation is not going to be conducive to anything. We have seen that, we have history teaching us.
And there are things that have come out of this wider discussion. The really big one that's come out at the end here is this one about starting with the patient, starting with the individual, isn't it? And that actually the social context is something that all of us need to think about. And very interestingly, for drug developers, it is the point about an easier, simpler regime, a quicker, shorter treatment, and of course quicker getting drugs quicker through the development process that's really important here. But I thought that was a very useful set of comments about that delivery ultimately is about whether or not individuals get what they need, and part of that is the drug, and a great part of it is the social context and the support they get, and indeed, actually, interestingly, the support the doctor gets.